decrees or orders regarding emergency medical service or assistance and as a part of planned surgery. But when we talk about treatment results, they are quite complicated. We have a very high mortality rate, a number of lethal outcomes. So we talked about it with Sergei Ivanovich and decided to organize this session, especially since we invited those clinics that have closer experience in terms of curing such complicated patients. Igor Ivanovich, I would like to ask you to go through our plan. You also have a plan, and on the left-hand side you have the sequence of the speakers and the way this will be presented. So we will make presentations, and then we'll have a time to ask some questions and to discuss in more detail some complicated issues. And so the first floor is given the main gastroenterologist of the Ministry of Health, Dmitry Bordin. Good afternoon, dear colleagues. I'm really glad to participate in this multidisciplinary symposium because we understand that working with such patients is our common goal. When we have varicose bleeding, we already understand that it's real trouble, and what we want to do is just to prolong the life of the patients until liver transplantation. So as for the reasons of these reasons, here we have a pressure increase also in the vena cava by over 12 millimeters, which leads to some disruption in the blood flow, and also it can be localized in portal vessels. We can have some other figures as well, but at the same time it's very important when the figures are exceeded, also classified as portal hypertension. Why do we have this pressure in blood vessels? Because it's quite proportional to the blood flow, and also it has certain resistance. When we talk about portal hypertension, its major mechanism is shaped by the resistance to the blood flow in the portal vein. We have some liver pathologies, sometimes can be explained by also some pathologies of the blood flow, but also it could be witnessed during liver cirrhosis. Well, basically the reasons are quite apparent. The main reasons is related to sinusoidal as well as to pre-sinusoidal as post-sinusoidal venous. We also can have some parasitic diseases, and yes, separately we have this post-sinusoidal diseases. We also have pre-liver and post-liver obstructions, and as for post-liver obstruction, this is the so-called body carrier syndrome, and that it has a direct effect on the heart that leads to pericarditis and also cardiomyopathy. So as for intraliver portal hypertension accounts for 80 to 90% of all the pathologies, but it's very important to understand that we have reversible and irreversible components. When it comes to the cirrhosis, of course, the major important things is fibrosis and regeneration that lead to certain resistance to sinusoids and terminal portal venules. But also we have reversible factors that we can somehow affect and prevent further development of portal hypertension. Basically, we understand that the result of portal hypertension, the formation of portal vena collaterals, and it leads to certain complications. We see that the most important and the most complicated complications is the enlargement of the blood vessels in the intestinal tract and also in the stomach, that leads to massive bleeding. We also have a risk of portal hypertensive gastropathy. It can lead to a very acute and chronic bleeding regardless of any vessel dilatation. And even more to say that we also have, in case of anastomosis of the rectum, it also could lead to bleeding amongst such patients. The second problem is that when we have this collaterals, we have stents that are installed to bypass the liver that leads to encephalopathy. We have to be aware of this problem, especially when we talk about surgical treatment and formation of the tips. And the next problem is development of ascites against this portal hypertension, and also a liver failure. We also have splenic, if we have high pressure in the splenic vena, then it can also can lead to encephalopathy, and it can lead also to hyperdynamic blood circulation, leading to some other problems. Well, basically, we have to state that portal hypertension has almost no symptoms, but symptoms appear when complications are already in place. When we have a very serious varicose bleeding, have very serious represented very serious hazard for our life, and this portal gastropathy can also be one of the reasons of such a bleeding, but esophagy, I have already mentioned that. So it forms all those clinical signs that we should be aware of, and of course we need to prevent them, paying attention to all those possible signs and symptoms that need to be treated. What about the diagnosis? Again, first of all, we have to perform a clinical assessment. Those symptoms that I had previously mentioned that have to be noted down, of course, changes in the gradient and the pressure in liver. This is no space for invasive intervention. We use non-invasive methods. We use CT and in order to analyze the abdominal space, and using, for example, the Doppler methods. Current methods, for example, fibroelastometry of the liver can also be used. But as for gastroscopy, we can also analyze the stomach and see portal gastropathy and see the risk factors within this area, abdominal and also the stomach. I'm not gonna go deeper into that, but using non-invasive methods, so we can see all those enlargements of the vessels and all these collaterals. The main reasons of the bleeding is the varicose veins that can be a little bit enlarged within the intestinal tract. For example, that's manifested within the patients with liver cirrhosis, 25–80%. Also, it can be provoked by stomach bleeding, and portal hyperextension gastropathy can also lead to this kind of bleeding. So we have also endoscopic classification of vein enlargement within the intestinal tract, portal gastroencephalopathy, and endoscopists are quite aware of that. You have to understand that the mortality rate during this acute varicose bleeding exceeds 50%, the threshold, and prognosis can identify it by the degree of our reserve liver capacity. and the amount of bleeding. And also there is a risk of recurrence within the first 1 or 2 years, and this risk attains the threshold of 50 and up to 75%. Of course, we can use endoscopic treatments or also use special drugs in order to prevent this kind of bleeding, but at the same time it can hardly actually affect and have a positive effect on the long-term outcome. So such patients really need to be treated. We need first of all to eliminate the reasons of portal hypertension, and also to diminish the pressure in this vein. We need to have on-time diagnosis and take all the measures to prevent river cirrhosis. As for those with a very close vein enlargement, so we can have non-selective beta blocking agents. There is also a risk of need for ligation, and we need also to see that here we have an example of this blocking agents that could also be used together with a selective one. Their dosage can be various and within dependent on the heartbeat, and it can vary within the range of 25%, which could be more efficient. If conservative therapy is not that efficient, then we could use tips or have surgical portocaval stenting, but we should regard the methods as like a kind of a bridge to the final treatment, I mean liver transplantation. And it's really nice that in the city we have a number of centers, including the Botkin Hospital, where this kind of operations are performed. Here we have all the theses that I have previously mentioned. Thank you. I'm sorry, I didn't mention from the very beginning, since we are quite have a certain schedule, and let's just stick to our time limits. 12 minutes, no more than that for one presentation. Irina Korzheva, responsible for endoscopic department in the Botkin Hospital. Good morning, dear colleagues. Thank you very much for such an opportunity to talk about our experience in one of the leading hospitals in Russia, and just to talk about talking about this problem. We understand that this problem is really relevant, and liver cirrhosis is one. Is one of the leaders that leads to lethal outcome. It's a non-tumor disease of the intestinal system, and a special survey was analyzed, and over the past 10 to 20 years, the number of patients with liver cirrhosis has increased by 60%, and it's also because of chronic hepatitis. There is a certain correlations between varices vena enlargement and the gravity of liver cirrhosis. Patients of class A, according to Child's Pugh scale, and 40% cases also have this varicose vena enlargement. Patients of class C, etc. So number of lethal outcome during the first bleeding in this case amounts to the threshold of 20 to 35%. The second case up to 50, 70%, etc. But also there is a high risk of recurrence, and up to 90% of the patients unfortunately have this kind of recurrence. We should say that this is one of the leading methods in diagnosis. Intramural endoscopy. The main task is not just to localize and to see this varicose enlarged vena, but also to prevent the recurrence, to analyze the walls of the vena, and also to analyze vasculopathy, see any kind of ulcer lesions in the mucous membrane of the tract, and and the stomach, and also to see any comorbid pathologies of the mucous membrane of the tract of stomach that could also be another sources of bleeding. So I'm not gonna dig deeper into that. We know that we have classification, usually a clashes Singer, so it is segregated in the first, second, and third stage. Here we have 2-3 millimeters for the first stage, 3 to 5 millimeters second stage, and over 5 millimeters for the third stage. And according to the recent classifications, all the previous classification will also be aligned with this approach, and we will have pretty much the same based on the average and middle size and small varicoses. And as for over 5 millimeters, this is the one that leads to major bleedings. We up to 1999, and we worked with a seronetal classification, and hardly anything changed even after that. According to that classification, this varicose veins can be classified regarding on their gastroesophageal varixes. So they analyzed in order to see cardioesophageal curve line. We have isolated curve line and the cover of the stomach in the first part of the room, and it's very important not only just for our treatment but also for analysis and on-time diagnosis. Right now we have a number of endoscopic hemostasis, and it's getting more and more perfect, but as of today, endoscopic ligations in the main approach in terms of endoscopic hemostasis and approach, especially for the tract and also for the stomach. The methods are a little bit different between during the ligation of the varicose large veins. We have a special means for ligation with a silicone rings and a special cap. As for stomach, here we have nylon rings with a smaller caps, and diameter is identified by the endoscope. So as for sclerotherapy, it was described a long time ago, and it's still used. So usually it is used to prevent the appearance of such large veins in stomach. It can also we can use intravasal methods and also paravasal methods. So these are two main approaches. But apart from that, it can be also this it's used for paravasal methods can be used as a main solutions for intravasal methods. It allows to have very solid, good cicatrix and very healthy cicatricial tissue, but at the same time can have some complications and can lead some bleeding, so that could require a very urgent intervention. The method is not that expensive during the procedure, usually require 15 to 20 millimeters of this solution of atheroscleral, and we have approximately 10 to 15 points, 2 or 3 millimeters per each. So we have 2 to 5 packs per the whole procedure. And one of the recent achievements in order to prevent this profuse bleeding, especially when it comes to the varicose veins, we can have self-displaced stents. As for hemostase, for this in the stomach, we can use intravasal injection of the glue-based compositions. We can use the bucrelate gista acryl. This is their pharmacological name. This method has quite a limited usage because this tissue glues are polymerized very quickly, and the time the endoscopic need has for it is no more than 20 seconds. And if there are some delays, then glue can paralyze not just the needle that is used for injection of this material, but unfortunately also biopsy channel can also be glued. That is why they try to restrain from this kind of methods. As for isolated veins or the antral part of the stomach, we can use just ordinary clips. We prefer to use long clips that are produced by many manufacturers with a total length of 135 millimeters. And as for indications for endoscopic treatments, well, there are a number of them. Well, first of all, we need to stop quite resistance bleeding, if we want to prevent a recurrence, and also we want to prevent then another bleeding in future as a result, and one of the side effects of this pathology. So talking about methods, yes, we can work on an patient basis, and of course very often we can monitor and keep track of all this bleeding, and we have seen a lot of such problems both in the intestinal tract and stomach. So we decided to analyze the past 5 years, and the number of the patients was 180 patients, and most of them, over 50% of the patients, had those persistent bleedings that were delivered to us by ambulances. So as for these recurrences and also persistent bleeding, of course we have here a algorithm based on the VENA-5.
And according to national clinical recommendations adopted in Orange in 2014, and the algorithm adopted in Botkin Hospital while treating the patients with bleeding, continuous bleeding, we use the following tactics. When the patient is in hospital, they are all brought into shock therapy of rehabilitation intensive therapy chamber, and there they identify according to hemodynamics conditions, depending on the stability or instability. Either we start from general hemostatic therapy or compensative therapy with vasoconstrictors, which are octreatides or remistid medicines. And in the first hour after they arrived, we should do emergency endoscopy. If immediately with the intensive therapy and rehabilitation chamber, reanimation chamber, we are invited for emergency endoscopy. And according to our experience, according to the results of endoscopy, most of the patients had continuous bleeding, 1.5 times more than with the stopped bleeding. And the next stage is installation of a stent. And well, if the bleeding stopped, out of endoscopic methods, we used lagering, and this is for most of the patients. And when we saw bleeding vein, we used endoscopic scanning and a special solution of etoxosclerol. And after it is removed, then if in case bleeding still continues, in one case we could install Danish stent if massive bleeding was provoked all over the gullet. Then the patients with the bleeding had surgery for the whole veins, and for 3 patients we had transtubular shunting. And unfortunately, in this group of patients, 10 people became in for mortality group. And according to the methods of endoscopic treatment shown at this slide, we saw that all endoscopic methods of treatment were divided in following ways. Most of the patients with the continuous bleeding, after the zone was installed, we performed endoscopic legging. Well, I'm sorry, I will speed up. And the results of the treatment was the fatal rate in this group made 10 patients. In our algorithms, we were also guided by early bleeding for 2 days or late bleeding for 10 days, and also at stopped bleeding we used sclerotics in 2 cases at isolated gullet or endoscopic legging, which made like excessive number of patients. As to complications that we have mentioned at early post-surgery period, it was pain in guts or dysphagy, but fortunately this number of patients is not considerable and they do not require any additional surgery. Main group of patients with continuous bleeding is prevention for the varicose disease patients treatment. These are 42 people, and for prevention treatment mainly we used endoscopic legging, and this was expanded veins of gullet and or stomach veins varicosity. We saw some complications in this group. This is less than 30%. These are local complications related to ligature applications and pains in chest. And there were no fatal cases. The devices we used are quite general. We make it according to general methodology, starting with the bleeding point, and if this is continuous bleeding, and in order to prevent a repetition, these will be the veins that are located in the cardio. Well, you are absolutely right, and according to the result of we've got some peculiarities. The only thing is that we are trying to make it with the endotracheal. Well, according to the results of our endoscopic treatment, this is endoscopic lagering, and as to the surgery, this is endoscopic surgeries, and then 7 patients had this kind of surgery, which made 6% only. The fatal rate didn't exceed 10%, and mainly these were patients either with the bleeding or with the repeated bleeding, and that is why for today I would like to say that out of all the endoscopic lagering is a golden standard for portal genesis, and this is a self-standing methods for prevention and incomprehensive with all the less invasive means. Even though Professor Korzheva used more time, we would forgive her, because on 26th of December, with the decree of President of the Russian Federation, she got an honored title, Honored Doctor of the Russian Federation. Let's congratulate her. So, Alexey Vasilievich, actually, this is a good thing. But, dear colleagues, we are here together, what for? Just to discuss generally known things, and these things are well known to everyone, and we have to discuss. And in order to discuss, we need not to give a lecture, but this should be mutual communication. So that is why let's stick to the time, so that we would have at least 1 or 2 questions, and we would also leave some time for discussion, because this is the most important thing in order to bring something out of this session. Do you agree? Yeah. So the next speaker will be Professor Shipovsky, Vladimir Nikolaevich, Hospital 57. Dear co-chairs, dear colleagues, during the last 10 years, we mentioned the strength and attention of clinical people to possibilities and results of endovascular technologies during treatment, in correction and manifestation of portal hypertension. And you could show basic methods of treatment, you know them very well. And endovascular surgeries at portal hypertension syndrome can be conventionally classified into 6 positions. The first one is a reduction of the spleen bleeding, which is a well-known manipulation, and main indication to that is osteit and hypersplenism. And what is the idea of this surgery? The idea consists in embolization and partial embolization of spleen, arteria, spleen vein, and we have to disconnect 2/3 of perfusion in order to partially decrease pressure of spleen component in portal pressure, blood pressure. And the main thing is to decrease the accumulation of medicine in spleen, and thus increase the peripheral blood. The disadvantage of this procedure is that it doesn't influence bleeding, and it's quite useless for that. And the positive trait is this: on the one hand, it's quite available and efficient, and the level of recommendation is C, limited possibility. Number 2 is also a very well-known procedure is in endovascular world. This is embolization of cardial veins of the stomach, for cardial veins of the stomach and thrombovene of the stomach with different agents. So the indication is strong bleeding from veins of gullet, which cannot be blocked with endoscopic measures. The efficiency is very high. If performed correctly, this methodology can reach 100% of efficiency. The disadvantage consists in the point that embolization of cardial veins increases naturally, and naturally increases portal pressure. And further on, these patients can have risks of bleeding. And at this slide, you can see embolization of left stomach vein with the spirals of And an interesting problem for this methodology is what to do with this kind of giant veins. Giant veins of the left stomach. You can see that the diameter exceeds of the portal vein exceeds it by 1.52 times, and for that we use a regional item which is supplied by a producer, and I will show it a little bit later. The third methodology, endovascular, the TIPS operation, transjugular intrahepatic portosystematic shunt. This is implantation into the tissue of liver, location of metal construction which is called stent between the portal vein and ceroic vein. It is done in order to decrease portal blood pressure, and it has also some disadvantages and some level of mortality rate. It increases encephalopathy, and also one of the problems here is that there is stent thrombosis. According to the data of the authors, it can reach up to 80%. In our methodology, I will speak a little bit later. And it has a high level of recommendation and a high probability. And the left part of the slide, it's before embolization, and then the right part, this is after stent implantation. Please pay attention that this slide shows not only anatomic component but also functional component after implantation of the stent. If you are careful, I cannot show you with the pointer. We have a rapid non-contrasting of left stomach vein, which is so-called a killer vein. Indications for the operation of TIPS, a very important aspect. This is a bleeding which cannot be blocked by medical endoscopic events, repeated bleeding after lingering, and also resistant acid of medical therapy. Contraindication, I am not going to enumerate those. I would like to indicate only the most important one. This is high level of hepatic insufficiency. According to Child Park, this is C, more than 11 items, and as to SML, it is more than 20 scores. Recommendations for performance of TIPS were reflected at the meeting of Russian Surgeon Society in Voronezh, with more than 700 delegates voted for the necessity to use TIPS operation to cure portal hypertension manifestation. TIPS surgery is one of the most complicated surgeries, very special ones. This is for hepatology, and these main stages are punction with the ultrasonic control, and also performance of hepatic veins and portal veins punction, and from the hepatic vein some node point, and approximography to work with the veins, which we actively use for these kind of surgeries. And I would like to mention that we are pioneers in carboxygraphy at post-Soviet space, but this is a specific theme for conversation. Then we perform angioplastics, implantation of stent, and measuring of a gradient, protocol gradient, and then polyfractional portography, and this is shown as 3D reconstruction, how to understand it, not to violate methodology. We need to locate stent into normal position. Here we see a brief clinical example at the left. This is before implantation of the stent. On the right you can see the red line showing the stent installed, and the left stomach vein is left here, and after a couple of days it will have a strong repetition of the bleeding, and the selection was to implant into left stent the so-called Templatzer vascular plug, which does not have any alternative for this position, and this really helps us. We also can use spiral for a left stomach vein, and our experience at present, let us say by the end of 2006, 2017, we had around 250, and here we see only part of our experience. By the end of 2017, we had 214 patients with TIPS, and what I'd like to characterize, this is quite a young age, 52 years mainly, and just pay attention, this is high level of hepatic insufficiency, and like 99%, and unfortunately, as etiological reason was chronic alcoholic intoxication, and the main indication was bleeding, and bleeding with ascites. Oh, well, here you see only a kind of remote result after 18 months, and in this group we had 141 patients, and I would like to attract your attention to the following thing. Yes, there is a mortal rate here, but it happened not because of the bleeding, and this is our task to get rid of this, and this was due to hepatic insufficiency because it influences the function of liver, and our data correlates with the data of our colleagues, because when we use stents, and it can improve results, this kind of stents can improve results of TIPS surgeries. At the previous slide, you could see the most ideal stent, that is American stent Viator for TIPS operation, but today we do not have such an opportunity to physically and technically use this stent, and it made us use this. This is kind of know-how. Now we are going to get a patent to implant two stents. That is external metal stent and internal graft stent, in order to improve results. The remote results, TIPS at ascites, a group of 72 patients also had a mortal rate from progressive liver insufficiency. A diseased person from St. Petersburg, 62 years, quite young, and after 6 months, this is how she looked. That is what she sent, and there was a surgery and plastics of the novel ring. And the fourth methodology is totally new, retrograde occlusion of stomach veins. That is called balloon occlude retrograde transvention obliteration. So this is a totally different thing. This is meant to analyze for varicose veins of the stomach with the different methodologies, not getting into details. So the advantages of this surgery consist in the fact that it doesn't have any mortality rate, and a disadvantage is that there should be a special anatomical reasons of so-called gastrosplenum anastomosis. And the next methodology, this is shunting of the portal vein at extrahepatic form, and here we have pressure in portal vein, implantation of a metal stent, and we have only one observation, rare pathology. And the last slide, this is a stent of low vena cava, and just for your understanding, this is one of the easiest surgery that can be used at portal hypertension at Budd-Chiari syndrome. Thus, low-invasive endovascular technology are efficient, prospective in treatment of manifestations of portal hypertension. They are element of conception of multidisciplinary approach, but unfortunately, due to some reasons at post-Soviet area, they are terra incognita. Thank you for your attention. Thank you. Any questions, please? Well, thank you very much for this report. Could you please tell, after TIPS, do you add something specifically, and do you get vasodilators, hypermerts, or some other medicines in order to prevent thrombosis and decrease encephalopathy? Medical therapy after TIPS. Well, of course, natural lactulose and hypermerts medicines are a totally obligatory component because patients in this or that degree have a progressive encephalopathy. And as to the diluting, first of all, this is post-bleeding, and this is huge trauma. And with the tissue of liver is expanded, and the stent is 10 millimeters in diameter with large amounts of blood, and from this position we are not afraid of thrombosis stent. I think I answered your questions. Oh, well. Vladimir Nikolaevich, one question. Tips, according to international, is it emergency procedure 70%? And in emergency, what is the percent of emergency tips for you? And mainly these surgeries are done in some of a remote period, and we have some group of patients, 3 or 4 people with a high bleeding. Black Moran zone, it doesn't prevent from the procedure. You have answered well. You had 3 or 4 people. Any other questions then? The next speaker will be Professor Vakarin. Good morning, dear colleagues. I would like to suggest our vision of treating these patients, our conceptual approach and the modern technologies in patients' treatment with portal hypertension. Clinic of emergency surgery of portal hypertension is located in 2 bases. This is Russian Scientific Center named after Petrovsky and City Clinical Hospital, where we have most interferences considering urgent character of this pathology.
I would like to say that this year is very important for our hospital because today we celebrated its anniversary from the point when we started. When we were based at this kind of location. It was actually done by Mr. Irrigation, also Mr. Petrovsky, and as well as Maria Patsiora. They organized the first department and started to work to quite not known domain. And thanks to Kim Nikolaevich Tetsanide, he also made a real contribution, and we managed to take it to a new step. And we performed actually the first liver transplantation. As 4 varicose veins of the tract and also stomach with bleeding. They have a very serious represent a serial hazard as for acidic syndrome as well as hepatic insufficiency. I would say this is one of the main reasons that leads to the liver transplantation. We have the following conception here. We first of all need to ensure that patients with such a syndrome of portal hypertension have a full spectrum of high-tech methods for diagnosis and personalized approach for selecting methods for treating any complication. And also we have a preemptive surgical and therapeutical control over pathologies in really suitable conditions for that. This kind of concepts, it's actually pre-identified the structure of our department working in this domain. You can see that here mostly we have both outpatient and outpatient monitoring, and we have over 2,000 patients on the regular basis with different forms of portal hypertension. We organize different consultations. We also use different endoscopic technologies and also endovascular surgery. This all happens in close cooperation with a hepatologist, transplantologist, hematologist, and also obstetrician gynecologist. We also have special schools for portal hypertension, and we organized special consultations to work with other departments as well. Here we can see cross sections of the hospital operations. Here we have different surgical interventions, endoscopic interventions, X-ray, endovascular intervention, laparoscopic operations, and other kind of surgical interventions. And you can see operations in other medical establishments. This is the figure. We have from 600 to 700 operations per year, but at the same time we can see that we have quite a high rate of endoscopic interventions interventions. And Mr. Zhigao, for example, one of our professors, with Mr. Shagin, they actually increase the number of endoscopic intervention, and it is done for primary and secondary prevention of further bleeding in future. Apart from that, in the polyclinic, I said, we have over 2,000 patients, and we have them on an annual basis annually. And this is the center for providing also treatment for pregnant women with this portal hypertension. So this is endoscopic intervention that we have. We should say that as for sclero-based interventions, they were brought to minimum, and also we also use ligations of the tracts using latex rings, and also used it's both for the stomach and tract, but it applies to the veins of the first type when they can be used within and treated within one loop. We have over 30 variants of portocaval shunting for patients with varicose veins, so over 30 options. But most cases we have either also use interposition of synthetic prosthesis that recently has been really on the rise in terms of the number of interventions. We also use here auto veins. In rare cases where we have a problem with the splenic vein, we can also use splenic renal anastomosis, and we have quite a big number of very rare forms of it. Here we have anastomosis of lower vena cava and sarcovena. So segmentary portal hypertension. Here we have isolated thrombosis of a splenic vein. It's one of the reasons to that is pancreonecrosis. Usually these veins are localized in the upper part of the stomach. Here are some of the patients, and there are some forms of interventions based on Chiari. This is a young man who had this Chiari disease. We used here anastomosis, so eyesight completely disappeared, and now he feels perfectly fine, even though I should say that during this kind of, in case this disease, we use shunting, portocaval shunting of as arterial vein. I should say that shunting is only done during the chronic disease, and I mean this very stage. But another alternative could be TIPS, and Valery Nikolaevich, he has already talked about this TIPS operation. And in case of liver cirrhosis, then of course it leads to a liver transplantation. And here I would like to show some rare forms during some portal hypertension. We also have this kind of forms. These patients should definitely demonstrate it here. We have different reasons that led to portal hypertension. For example, there was a splenectomy, then led to pancreatitis, then it also led to thrombophilia, and also thrombosis of the portal vein, as well as the problems with the splenic vein. And we have here a dilated splenic vein, like I say, yes, so thrombosis of the portal vein, and also Chiari syndrome was also developed, and we also have obliteration of hepatic of the veins, and also thrombophilia. So a complete obstruction of occludes was installed on the proximal part of the stomach, and it allowed to avoid any resistant syndrome that had quite a complicated form. And within a period of 3 years, she also we used a special solution and further monitoring with intervention. She was delivered to our hospital in quite quite difficult situation. We installed a shunt first in the lower vena cava, and then we also decreased the amount of the liquid in the lower part of the stomach. Then we performed a distal resection of the pancreas, then also removed fistula, and after that, against vertebral therapy, we also had an intervention in the portal vein. So apparently you can see that we have the fistula that was resected from that patient. Another patient, a pregnant woman with different aneurysm in the splenic arteria, splenomegalis, and also portal hypertension and varicose veins. So splenectomy and aneurysm were some of the major causes to that, but she delivered a baby at the 38th week. What about the liver cirrhosis? We have 5 clinic groups of patients depending on the gravity of this disease. So unlike child's classification, and I would say that this kind of classification fully complies with our needs, and also we have quite a differentiated approach, and our intervention also depends on the group that the patient belongs to. So this classification is not very at the same time maybe helpful enough from the information point of view, but here we have some clinical groups that will still give us an idea as to how we can segregate between different patients. So we have different algorithm behind this segregation regarding treatment, diagnosis, etc. It also has a number of factors involved. For example, the compensation rates, other diseases or pathologies that also go together with disease. So we have, for example, the first group, Group A, where we used most cases portocaval shunting, or Group C, where we use conservative therapy. And so there are different specialists who work with different approaches of that. Portocaval shunting during liver cirrhosis. So usually we have the following selective type of this shunt, and we have distal splenorenal anastomosis, or spleen caval vascular anastomosis, and others. So we a little bit modified these technologies, and we can see here a splenic vein where actually anastomosis is performed. We work in the proximal part of the area and create quite a formal way of anastomosis. This modification allows to minimize the possible negative effect of intervention, minimize possible complications that could be there, and also it could increase the number of patients that who could be exposed to this kind of operations. Here we have a post-operation monitoring system that could also be used together with this splenorenal anastomosis. As for distal splenic caval anastomosis, it's here performed within an area of vena cava, and first we go from the vena cava, then we have a reinforced prosthesis, and it goes up to the pancreas. So, and not so often, but still we also use a super selective gastric caval anastomosis with the interposition of synthetic prosthesis. It is used like is in the stone, can help us to eliminate all those varicose veins, and you always have to remember when we have liver cirrhosis together with fibrosis, you have to be aware of Cuvier-Baumgarten syndrome, because after, for example, selective portocaval anastomosis, you also have to dissect a functioning umbilical vein. It is particularly important. So you can actually see it on the left-hand side. It's really visible. Otherwise, it can be lead to a very serious encephalopathy. Recently, we also have been developing laparoscopic approach. So you can see an operation of distal anastomosis, and here you can see a splenic vein, and also the frontal and vein. I should say this operation requires very serious approach, and also all the results should be analyzed. We need to clearly identify all the vessels and the area that will be exposed to the anastomosis. Here we have another example. This is a TIPS operation, and here we have a special probe, Blackmer probe. I would say that this is one of the major achievements over the past years. This is a low invasive intervention. We should say that we have really improved our capacity in this very sphere, which of course at the same time doesn't mean that we don't have any limitations at all. We classify this kind of not anastomosis, but this type of operation to different types of shunting, and I think that it will be probably used in bigger quantities in the future. I think this is something that could be as just to go as an option to liver transplantation, and especially it's suitable for patients with fatal bleedings, where it's not possible to block bleeding, and it's not possible to have any other kind of intervention. So we cannot act laparoscopically, and we cannot have any other types of shunting. Yes, I'm almost done. And we can also have some palliative interventions, laparoscopic operations. So you can see it actually on the screen, and also we have quite a number of laparoscopic approaches that are now being developed. I would also like to talk about some modern trends and approaches, but I think we don't really have the time for that right now, or do we? Thank you very much. Do you have any questions? Then I have the following question to you. What is a super-selective anastomosis? What is a super-selective anastomosis? Well, maybe it's just my personal term, or something that I coined on my own. It means that we have a coin when we have anastomosis and when we have a certain decompression to perform. Yeah, so we have a vein and the one that goes out of the stomach and responsible for the outflow, blood outflow. So unlike just ordinary anastomosis with coronary veins, etc., I mean, it's a little bit different. It's quite a selective, just a little bit more selective than an ordinary one. So you said that TIPS is a total portocaval shunting, but it's not absolutely correct. This is departalization, and it can be classified like that if you fully comply with the specified methods. And if something is violated, then there could be a problem with the blood flow, where blood could go both to the splenic and to the portal veins. I should say that this is really important to have this kind of segregation, where we have anastomosis with a shunting, with a portal vein. It creates a colossal burden on the central hemodynamics. We definitely need to study their blood functions, and in case of quite decreased blood outburst, so it could not be really suitable. The point is selective anastomosis is even though that they still not as popular as TIPS, for example. I would like to say that in this case we also need to consider such factor as decompression. Otherwise, we wouldn't have so many cases of encephalopathy or shunting. So if you compare TIPS and selective anastomosis, so you can hardly do that. I agree on that point. Thank you very much for such an interesting presentation. It's true that you have a very considerable experience regarding the support of hypertension, but I would like to say about this PCR surgery. Have you ever used it in your hospital recently, or were you satisfied with a lower invasive intervention? Just like Alexander Konstantinovich said, so operations and those direct intervention in the veins of the stomach will still be an integral part of the surgeon scope of activities. Well, of course, it is suitable for the splenic portal veins, where you cannot perform neither TIPS nor any kind of shunting, and when this is the only option that could be used. And secondly, when this operation was created, it was mostly meant for blocking this bleeding, just to save patient's life. After that, you can do anything you want with the patients, including those with liver cirrhosis. I mean, transplantation or TIPS, it doesn't matter. I talked about different cases. I would love to talk about these realities, but we have over 2,000 patients of that kind in our hospital. We can see those colossal problems that we have for helping those patients. And I should say that if, for example, we organize master classes, we go to different regions, and we organize some training, I should say that we really want somewhere on the outskirts of Russia, if it's not possible to apply these high technologies, still doctors could stop this bleeding, I mean, gastric veins in an efficient way.
This surgery can save lots of people. In a group of patients with thrombosis, 30–40% with complications of this kind. And what we can do in this situation, sometimes when we have to make this surgery, and it's mostly applicable when nothing else is possible. And yes, this surgery is here, it exists, and it will exist. Well, thank you. We have one more speaker. This is Pavel Drozdov from Botkin Hospital. Good morning, dear colleagues. As to all the modern methods of correction portal of hypertension, we have already discussed, and for a year and a half, all these methods are used in Botkin Hospital, and within this period of time, we got some changes in our vision of this problem and approach to the treatment of this group of patients. Please allow me not to stop at the methods which has already been described by previous speakers. Well, the only thing, while observing patients after liver transplantation in our hospital, now I have 36 patients with this problem, and liver transplantation is the only pathogenetic treatment of this group of patients, which influences over all the complications of portal hypertension for these patients. And this makes this technology the surgery of the first selection for this group of people. And it's quite clear that not all the patients with portal hypertension, and I would like to mention that at present liver transplantation is actively developed in our country, and within the last 2 years we got increased number of centers of transplantations in the Russian Federation. Before it was a prerogative of federal centers, and now these surgeries are done in city hospitals in Moscow and in regions as well. In Moscow and in Russia, for the last 5 years, our we increased the number of surgeries by 70%, and out of 505 operations on liver transplantation in Russia, 337 was done in the centers located in Moscow. It's quite clear that the presence of portal hypertension cannot be the only indication to put into waiting list, because the problem of lacking of donor organs is not solved in any country of the world. That is why, judging from native and foreign recommendations together with portal hypertension, there should be a presence of hepatic inconsistency. The presence of hepatic inconsistency is identified by MELD score, and if the score is more than 15, they can be included into a waiting list. Besides, waiting lists can be for the patients with the complications of portal hypertension, that is blood pressure. Well, we will add your time just in case. Well, if there is a bleeding of varicose veins with the diuretics or liver encephalopathy. Thus, during primary consultation of patients with liver cirrhosis, portal hypertension, these patients can be divided into two groups. The patients which at primary examination have indications to be put into waiting list to transplant the liver. These are with hepatic insufficiency and also varicose bleeding from veins of stomach or gutter, or the resistant ascites. And they should be sent directly to transplantation center, and then they are put into the waiting lists, and transplantologists provide all the necessary surgical interference for them to survive until the transplantation time. But there is a group of patients with portal hypertension, with varicoses, and with some liver insufficiency, with the MELD less than 15. While preparing for this report, we decided to assess how big is this group of patients. We took 100 patients in Botkin hospital with liver cirrhosis, and they had portal hypertension, and most often it was revealed through varicosity of stomach and gullet veins, and in 22% of these patients MELD was less than 15, and they never had bleedings before, and they didn't have a chance to be put into the waiting lists. So 7 patients had hypersplenism, and they didn't have indications to be put into the waiting list. Some of them had varicosity for veins of stomach or gutter. And the group of patients who at primary examinations do not have indications to be put into the waiting list, 31% of them are diseased, and the treatment of this group of patients is of great importance, because while we direct the transplantation centers, transplantologists do not put them into the waiting list. They send them to dynamic observation, then they go to the hospital with different kinds of complications, with the varicosity around 50%, and besides, they can have the interferences most developed in that clinic, which will further makes it easier or makes impossible the further transplantation of liver. Thus, a great number of modern less invasive surgical interferences as portal hypertension creates great number of advantages and disadvantages, and each of these specialists resolve that the tactics of this patient's treatment should be identified by multidisciplinary discussion. With the example of Botkin hospital, and we have discussion of 10 different professionals, and our approach to identifying candidates for liver transplantation is for those who have MELD less than 15 and who didn't have bleeding or ascites with viscosity of veins of stomach or gullet. This is less invasive endoscopic interference, sclerotic lingering, but if they have splenism, especially with hepatic cirrhosis and virus hepatitis, when they need antivirus therapy, these patients have lingering and part amputation of spleen. And hypersplenism, part of spleen, and Also widening of gullet, and we know that these patients have indications to have the distal shunting. Thus, the treatment of patients with portal hypertension should be done in a multi-profile hospital with the usage of all the modern ways of surgical corrections, including liver transplantation. Thank you for your attention. Thank you. Any questions? No questions. So then we have some time for discussion, just to discuss the reports and express your points of view. Is anybody willing? Honorable Igor Ivanovich, Alexey Vasilyevich, Professor Vaskanyan, dear colleagues, I'm sorry, member correspondents of Academy of Sciences, thank you. Oh, well, thank you for this chance. I would like to first of all say that it was very correct beginning, that this is a very hard problem. It's really hard, and it's not only hard from the point of view of urgent surgery, which was mentioned today for many times, but also selection of correct tactics and algorithm. If you allow, I would like to show you a couple of slides related to how this problem is considered by clinics who make transplantation procedures. Just 1 minute and not longer. So, from the point of view of transplantologists and basically hepatologists and all the people involved into this process, portal hypertension is a syndrome. And well, to say that the only pathogenetic method of involvement, as it has been mentioned, is liver transplantation. If we consider planned situation, portal hypertension as it is not indication for liver transplantation. This is the degree of compensation of liver function and other indications which are present here at the slide, and I'll be very brief. And first of all, we're speaking about hepatic form of hypertension, portal hypertension, identified by liver cirrhosis. Just a moment, I will show you a couple of slides. For transplantologists, it's very important to see the element of patient's preparation for liver transplantation from the point of view of pre-surgery correction of possible risks related to bleeding from varicose and spined veins of the gullet. If we speak about the patient who is going to have liver transplantation, that is related with decompensated hepatic cirrhosis or subcompensated hepatic cirrhosis with the indications, then we have to assess the degree of portal hypertension according to varicosity in esophagus veins and threat of bleeding, because the correction of portal hypertension is done for these patients not immediately, and we should understand this. The bleeding can occur intra-surgery or at early surgery period if we have a heavy degree of varicosity in gullet veins. So they should be prepared before the surgery, and less endoscopic means are preferred here, or to have correction of the threat of bleeding before transplantation. If a patient doesn't have expressed degree of varicosity for esophagus veins, this procedure is not needed, and then a liver transplantation is safe from the point of view of bleeding in pre-surgery period. This is objective. If a patient at this stage doesn't have indications for liver transplantation, but this is a young patient with hepatic cirrhosis, and we expect that with the time they can have these problems and they then do not have a varicosity, then correction of portal hypertension is not required. It's quite clear, but at expressed portal hypertension of 3rd and 4th degree of vein, it's possible to done a shunting interference. And overall tips procedures. I would like to show you this slide from the point of view of transplantologists. The most optimal option for shunting for these patients is partial options, the so-called or coronary or resention, or so to speak, to using such a shunt, which can be disassembled further on during the transplantation process if required, because further on we can speak about controlling the bleeding for hepatic transplantation. Well, basically that is all I wanted to say. This is the idea of transplantologists about this problem. Thank you. Anybody else? Dear colleagues, that is a very good conference arranged in a very good way, and I believe it was very well marked that we have multidisciplinary approach. I would like to congratulate Irina Yurievna with the degree she got, and also the point that in Botkin Hospital for the first time in the country they applied the method of compositions introduction. Unfortunately, I couldn't ask that question, but I wanted to ask a couple of words about methodology and to ask whether there was embolic complications after this methodology. And as to exchange of experience, possibly we are also going to use this composition through our practice. But this methodology, if it was performed, but it was performed for the first time in the country, nobody has done it before. And as regarded endoscopic idea of this problem, I'll say briefly, I wouldn't like the accents to be put for the direction of clipping and sclerotherapy. Actually, endoscopic lagering is a unique methodology for today, and it helps not only to block bleeding, but also to prevent repetition of bleeding further on. And sclerotherapy, actually, this was specified in the Wien conferences, and it is no longer used. And this methodology is not even at the stage of fighting bleeding, and it goes to the stage of treatment post-surgery complications and post-endoscopic lagering complications. That is why sclerotherapy is no longer present here. As to clipping, it's not there at all, because as an urgency measure, if you do not have anything, you can put a clip at the vein, but further on, the clip will make a repetition of bleeding. And I believe that we should develop this direction for endoscopic lagering of stomach veins, and I agree with the opinion of Gary Vaganovich that lagering of stomach veins as well as through surgery will have good results, and in the hospitals where there are no high technological methodologies, namely these two methodologies to treat stomach veins, will have advantage in comparison to sclerotherapy and in comparison to clipping. Thank you for your attention. Thank you. Good afternoon, or good morning. Well, actually, the conference is very interesting, and I was thinking what actually happened. Back in 2014, we had a meeting of surgeons in Voronezh, where we had preconceptions about the bleeding during portal hypertension through varicose veins of esophagus and stomach. We had 120 participants of the meeting. We discussed every point and confirmed every point of the session. What was the conclusion? The conclusion was that not everyone can treat these patients. They require step-by-step treatment, and it depends on the capabilities of the hospital the patient is brought. What changed within these years? Nothing changed. The algorithm of diagnosis and treatment is the same. This is identified not only with the class of hepatic cirrhosis, but also with the complications. And we speak about patients with complications of portal hypertension and with resistant ascites and varicosity in gullet and stomach veins. And we understand that the final way of treatment is liver transplantation here. But the USA makes 28 transplantation for 100,000, Europe 12, and Russia 2.6. No matter how hard we try, we cannot tell that we are ready for that today. And then we have a question: what will make us prolong life to these patients? And one of the bridges which will help to prolong life of these patients is comprehensive therapy, combined therapy, which was elaborated and which was confirmed as consensus. What does it include? It includes at bleeding of the first stage, obligatory blocking of bleeding, lagering at a dry esophagus, then a hospital, daily hospital, please direct your patient for the second stage. What's next? Then identifying of class of liver cirrhosis, liver encephalopathy, and also the capability of portal vein and shunting capabilities. So the shunting results in hepatic encephalopathy, and we have published an article which is called hepatic encephalopathy before and after TIPS. If we select patients, and adequacy of selection is that we didn't take those patients who had a PHQ more than 11. We didn't take patients with hepatic encephalopathy, and we didn't take patients with the infectious process, and we didn't take them with thrombosis of portal vein. What we got as a result, if we adequately select patients, then the level of hepatic inconsistency, well, it happens not for everyone, and it can be corrected quite easily. And the last thing I would like to say, we have accumulated experience for more than 250 patients with TIPS. What we got as a result, we have patients who before transplantation lived from 3 years, and somebody lived up to 7 or 8 years. How we managed that? And not only because we worked TIPS and it worked perfectly, and then we got necessity of repeated interference after TIPS. There was thrombosis, and we did angioplastics, and if necessary we installed another stent. If in case of necessity, we also done combined endovascular treatment, and I should say that due to that we managed to prolong life of many patients. And for today we have a joint experience with transplantologists, transplantation of 44 patients, and out of them 32 had solo endoscopic ledgering as a method of blocking bleeding, and for others in combination with TIPS. I should say that the problem should be solved in this direction, and all of us should work for the same thing. Everything has a meaning. Of course, there is a group of patients which should be operated on, but we are speaking about the hardest patients with B or C hepatic cirrhosis, for whom the risk of open surgeries is very high, and the algorithm of actions in comparison to the consensus is almost the same. It was just added by new methodologies, but I believe that it should be put as basis for treatment of this category of patients. Thank you for your attention. Thank you. Dear colleagues, well, I should say a couple of words about the problem that we have not touched upon that much. This is extrahepatic portal hypertension, and there are only 10 or 15% from general population, but these are patients of a very special kind. And I should say, well, in our clinic we have large experience of mistakes for these patients, and this is colossal. Everybody knows cirrhosis, but as to extrahepatic patients, nobody knows how to deal with them, how to use anticoagulants for bleeding because they have thrombosis, and practically there is no experience. And in recommendations, there are no accents for these patients. They make a huge group.
30%, even 40%. These are patients with leukosis and thrombosis of the portal system, non-endoscopic, not endovascular, and it's not possible to help them in this way. So this aspect during the next conference should definitely be focused on. We have a very vast experience, and we're ready to provide consultation and accept these patients. And a few words about pregnant women. And unfortunately, those with portal hypertension, they are not accepted there. It's strictly forbidden. This is a special group of patients, and based on our hospital, we created a special center for treating and for working with such a pregnant women with a portal hypertension. We're ready to accept them because they need to be treated very delicately. On one hand, there is a risk of bleeding, the risk of thrombosis on the other hand side, and premature delivery could also be the case. Thank you very much. Dear colleagues, I would like to also all the questions that I raised during my presentation actually showed this something that we are now doing. There is now a contradiction or trying to oppose one method to another. We have indications for each of them, depending on the gravity, localization of the veins, and many other factors that also have a direct impact on the selection of the treatment methods. And I'm very thankful to the department of Mr. Zativakhin because he developed and also popularized the method. So this is a great achievement in general. This technology was really pioneered by him. But you have to understand one important thing. I mean, the ability to perform this operation depends a lot on the transplantation provision in general. In the country, there is a direct link between the two. If you ask in the Western world what the direction is, of course, we have low invasive intervention, and then you can send the patient for transplantation. We have so it could be either TIPS or ligation. But also, I mean, when it comes to transplantation, do we have such an opportunity? Can we do it considering the geography of the country? They can see it every single day from Kamchatka to Kaliningrad, and I see what is happening in the country when it comes to such patients. And when you say about something about such high-tech technologies, well, that is a premature discussion. Of course, there is a need to create centers of computation, specialized centers in different regions, so that you can actually provide this service. You need to develop logistics so that after primary help, when you work with bleeding, then you can have those patients transported within this logistical context to the centers where different intervention could be performed, depending on the above-mentioned factors. That is why I would like to highlight again, no opposing between the two. So, and you, my dear colleague, if you say that we talk about 8-year very good results after the operation, that is really nice. But at the same time, the situation in general is not assessed very highly. I mean, the satisfaction level is not very high. So these results, they are quite empirical. We just have these points of this course. But have you ever valued any of those components in this situation? What is more important? Is it aside or albumin or aldotransbalmin? Now, the most important thing is to talk about the organizational issues. I think that you should pay attention to that. I'm asking for your assistance to discuss it a little bit later, to tackle different organizational issues. I just wanted to say that if we have liver cirrhosis B and C, and then at least he lives for up to 10 years, it's just because the treatment is quite suitable. Yes, 4 or 5 times we different correction methods can also be applied in these cases. You know, when we with Igor Ivanovich decided to prepare this symposium, I had the following impression. Well, it was really harsh. Those working with ambulances, it's like a black hole in terms of the materials, staff, general efforts that used. Again, this Blackmore probe. I think that we already should install a monument in his honor. Seems like there is no way out. But after some preparatory works and after today's presentation, and here is some joint works that should be performed together with hepatologists. There are some works for liver transplantation. It's also a case that can be performed. Yes, still risks are quite high. If we should say say that out of 500 liver transplantation, 308 of them were done in Moscow. And of course, there is still work ahead and work ahead. And so we could take some other steps to improve this indicator. So if we comply with the principles that we so far used during this symposium, there is a chance to improve these results. We are really running out of time, almost no time left. After the first presentation, by the way, I didn't announce a question. That was my mistake. I'm really sorry for that. I would like to say the following. Can we actually say that the technology's development has been finalized? No, that would not be correct. That position would contradict completely to our today's reality, and it would contradict the development of the surgery in general. For example, if we talk about laparoscopic surgery, yesterday they just started to perform appendectomy, and now gastrectomy is performed, as well as, for example, esophagus resections. Is it a progress in the sphere of endoscopy? Yes, it is. And we have just heard today that we talked about splenic renal anastomosis that was performed laparoscopically. What it's all about? Isn't it about a new technology? Yes, it is. Or, for example, endovascular methods. When something is missing, it does not necessarily mean that everybody have to stick to that reality. We need to keep pace with modern trends and also to keep abreast of the modern technologies. It's imperative, but it just needs to be developed. Or, for example, let's say about a few words about endovascular surgery. So you see that step by step, it is kind of stealing some points from open surgery or larynx syndrome. This is quite a typical operation that was done with aorta shunting, but right now it is just performed on a single basis. Endovascular approaches are everywhere. Or, for example, renal hypertension, vasorenal. So what should we do with it? Yes, we used to do it, but practically we're not doing that right now. There is a good expression amongst the surgeons. Practice is the truth criteria. And now speaking about pathological operations, Marina Evgenievna has contributed a lot to that. So it's really colossal. But as for our clinic, which is also works with portal hypertension, the last pathological operation was performed 4 years ago. Why? Not because I don't know how to do that or my colleagues know nothing about that. No, but because other methods were put in place. You see, for example, all those esophageal bleeding and stopping of this bleeding, sclerosing. Or shunting, for example. I hardly have any experience in the later one, but the importance of which is really changing. Ligation, okay, we ligate, and we do it on a repeated basis if needed. As for sclerotherapy, still had some complication. That's why it was less efficient, and our life gave us responses. And the last thing that I wanted to say, we have some clinical recommendations, and it's not just about this part of work, but there are some clinic recommendations. Clinic recommendations represent a particular direct line as to how we should do this or that thing. But there are other opportunities apart from that, and we cannot do nothing about that. I've said many times, Russia is huge. Even in Moscow, we have different diverse methods. That is why clinical recommendations, they still at least must be be our guideline number one, our master plan, and at the same time it might vary depending on each particular hospital. We can develop different treatment protocols, and if we don't have this kind of thing, then proceed to the things. If you don't have materials for ligation, no, our specialists do that. So then you can choose a different methods, but at the same time you must abide by clinical recommendations. And the last but not the least, I frequently mention that everywhere clinical recommendations must not be regarded, should not be regarded as a legal document. It should be regarded as an assistance, and but to do that, you have to understand that hospitals must also have their own protocols, probably based on those clinical recommendations. And then you will be able to address this information to the chief doctors, to the administration, to the lawyers, so that they can understand that you cannot demand something that is not feasible. But we need to also keep in mind the capacity of every single hospital, even though that we still must comply with this procedure, with this guideline. Thank you very much.